I have to be honest with you. I was looking at the stack of books for this session, Miller, Morgan, the ARC notes, and I had this moment of, well, hesitation.
Oh.
Usually when we talk about eye surgery, my brain immediately goes to cataracts. It goes to a 15-minute case, maybe some sedation, coffee break, and we're done.
Right.
But looking at these papers on vitreoretinal surgery, this feels different. This feels heavy.
That hesitation is your survival instinct kicking in. And honestly, it's accurate.
Okay, that's not reassuring.
No, but it's important. If you walk into a vitreoretinal or VR list thinking it's going to be a cataract plus day, you are going to get burned. Heavily.
Cataract plus. That's exactly what I was worried about. It seems like a common trap for residents.
It is the classic trap. But the sources we have today, especially the notes from the long and short cases, they make it very clear. VR surgery is a completely different beast.
Yep.
Well, we aren't just cleaning a lens here. We are working deep inside the eye in the posterior segment. We're talking about the retina, the vitreous gel. Essentially, we are operating on brain tissue that just happens to be sitting inside the eye.
That is a terrifying way to frame it.
It is, but it's true.
But it sets the stage for why this is such a favorite topic for examiners. I mean, I've seen the papers from Gujarat University, and this topic just keeps coming up. Long questions, vivas, tricky little physiology short notes.
It comes up because it sits right at the intersection of everything difficult. It's microsurgery, so you need absolute total stillness. It's often done on a very sick diabetic patients with a lot of comorbidities.
Okay.
And then, and this is the part we're really going to dive into, you have this collision of physics and pharmacology with the gas bubbles and nitrous oxide. It's a goldmine for an examiner who wants to see if you actually understand physiology or if you've just memorized a list.
Right. They want to see the application, not just the recall. So let's do this properly. I want to walk out of this deep dive with a gold standard answer. If I'm sitting across from that examiner and they ask me to frame the anesthetic management of VR surgery, where do I actually start? Do I just start listing the different surgeries?
No, you start with the environment. Before you even touch the patient or the drugs, you have to paint the picture of the room. This is what sets VR surgery completely apart.
The room itself.
The room. Imagine you are in the theater. It is pitch black. The lights are off because the surgeon needs to see through a microscope into the very back of the eye.
So you're sitting there in the dark.
You are in the dark. You are isolated. The patient is draped from head to toe. I mean, literally a tunnel of drapes. The operating table is often turned 180 degrees, so the surgeon is at the head, and you are, well, you're down at the feet or way off to the side.
Which means the airway is where?
The airway is in another zip code. It's buried under the sterile field, 5, maybe 6 feet away from you in the dark. If that breathing circuit disconnects, or if the endotracheal tube gets kinked, or if the airway obstructs,
you can't see it.
You can't see it. You might not even hear it over the noise of the vitrectomy machine. You are flying entirely on instrument rules. You are watching that capnography trace and that pulse oximeter like your life depends on it. Because the patient's does.
Okay, that visceral image actually helps a lot. It's not just an abstract airway access is difficult. It's you are physically separated from the airway in a dark room.
Precisely. And that brings us to the second pillar of why this is so hard. Time.
Right, not 15 minutes.
Not even close. A standard cataract is 15, 20 minutes. A complex diabetic delamination or a giant retinal tear, you could be there for 2 hours, 3 hours, even longer sometimes.
So you have an elderly patient, probably with diabetes and hypertension, buried under drapes in the dark, who have to lie absolutely stone cold still for 3 hours.
Stone cold still. And I don't mean mostly still. I mean micron level stillness. If they cough, if they buck, if they even take a massive gasping breath at the wrong moment, the surgeon's instrument can tear the retina.
And it's game over.
You can turn a repairable eye into a blind eye in 1 second.
No pressure then.
Right. So when you are framing this for the exam, you define it by these constraints. Limited access, prolonged duration, and the absolute requirement for profound akinesia. That is your opening statement. That's how you show the examiner you get the big picture.
Limited access, prolonged duration, absolute akinesia.
Got it.
Okay.
I've got the framing. Now let's look at the pathology. The sources mention a big 4 when it comes to indications. What are we actually treating here?
For the exam, you need to be able to rattle these off cleanly. First is retinal detachment.
That's the emergency, right?
That's often the emergency. The retina peels off the back of the eye like wallpaper. Second is vitreous hemorrhage that's bleeding into the vitreous gel, usually from complications of diabetes.
Okay.
Third is macular holes, a literal hole in the very center of your vision, the macula. And fourth is the big, broad category of advanced diabetic retinopathy complications, like tractional detachments.
It really feels like diabetes is the shadow hanging over this whole topic. It absolutely is, and that matters hugely for the anesthetist. We aren't operating on healthy 20-year-olds. These patients have systemic vasculopathy. Their kidneys might be shot, their hearts could be ischemic, their autonomic nervous systems are dysfunctional, and their stomachs are often full because of diabetic gastroparesis.
We'll definitely get to the pre-op assessment in a bit. That sounds critical. But I want to clarify the surgery itself. Part B of our outline here talks about basic concepts. I see the term PPV everywhere in the notes. Pars plana vitrectomy. What is actually happening during a PPV?
Okay, good question. Think of the eye as a sphere. To get to the retina at the back, you have to go through the white part of the eye, the sclera. The pars plana is this specific safe zone on the sclera, just behind the iris.
Right there.
Because it's an anatomical no man's land, there are no major blood vessels, and crucially, no retina there. It's the perfect place to enter.
So it's the entry door.
It's the service entrance, exactly. The surgeon makes 3 tiny holes, we call them ports, in this zone. One is for a fiber optic light pipe so they can see what they're doing.
Right, because it's dark in there.
Pitch black.
Okay.
The second port is for an infusion line to keep the eye pressurized with fluid so it doesn't collapse when they're working. And the third is for the cutter, the vitrectomy probe, or vitrectome. It's a tiny, high-speed guillotine that nibbles away and aspirates the vitreous gel.
They eat the gel.
They remove it completely. The vitreous is usually the problem. It's either full of blood or it's pulling on the retina, so they have to clear it all out to create a workspace.
Okay, that's the PPV. But the outline highlights a specific distinction here that Miller's text makes. It contrasts vitrectomy with scleral buckling. And there's a big warning sign next to scleral buckling saying, pain and reflexes. Why is the buckle different?
This is a crucial distinction, a very high-yield point for exams. In vitrectomy, you're working inside the eye. It's incredibly delicate, but it's not necessarily painful in the sense of tugging on deep, sensitive structures.
Yep.
Scleral buckling is different. It's more like an external plumbing job. The surgeon takes a silicone band of buckle and wraps it around the outside of the eyeball.
Like a belt. To squeeze it.
Exactly like a belt. They tighten it to indent the wall of the eye inward, to push the sclera against the detached retina, closing the break. But to put that belt on, they have to slide it under the extraocular muscles.
Ouch.
Ouch is right. They're physically hooking the muscles and pulling them out of the way to pass the band underneath. That traction on the muscles is the single most potent trigger for the oculocardiac reflex.
The famous 5 and dime reflex.
The very one. We'll dive deep into the physiology of that later, but just remember this for now. If the case on your exam paper says scleral buckle, your brain should immediately think high stimulus, significant pain, and a very high risk of bradycardia.
And if it says vitrectomy?
Your brain should think precision, stillness, and worries about intraocular pressure and gas.
That's a great heuristic. Buckle equals bradycardia. Vitrectomy equals stillness.
You've got it.
Now, looking at the anesthetic requirements, the notes call these the 5 pillars. This feels like the perfect skeleton for a written answer.
It is. If you are writing a theory paper, these are your paragraph headers. We've touched on them, but let's formalize them for the exam.
Okay, pillar 1.
1. Analgesia. The eye is richly innervated. It hurts, especially a buckle.
2.
2. Akinesia. We've said it, but it bears repeating. The eye cannot move at all.
3.
3. IOP control. Intraocular pressure. You want a soft eye. If the pressure is too high, the surgeon can't work and it makes the tissues bulge. If it spikes suddenly while the eye is open, the contents of the eye can prolapse out. It's a complete disaster.
So smooth sailing, absolutely no coughing, no straining.
0. Which leads directly to pillar 4, systemic immobility. We talked about the table. Can this specific 80-year-old with congestive heart failure and severe arthritis lie perfectly flat for 2 or 3 hours without their back seizing up or their lungs filling with fluid?
A question we have to answer beforehand.
Absolutely. And that brings us to the 5th and final pillar,
Which is
cooperation. This is the big variable. If you are doing this under local anesthesia, the patient is awake. They are buried under drapes in the dark with strange noises happening. They have to be able to lie still and follow instructions. Look down, look left, don't move, don't cough.
And if they can't?
If you have a patient who is deaf or confused or speaks a different language or is just terrified and claustrophobic, local anesthesia is a setup for failure.
It sounds like the curious resident, myself included, usually misses that one.
Yeah.
We focus so much on the technical question of, can I block the eye, that we forget to ask, can the patient actually handle the experience?
Precisely. You can have the most perfect, dense block in the world. The eye is frozen solid. But if the patient has a panic attack under the drapes because of claustrophobia, you're going to be converting to a general anesthetic in the dark, in a panic, with the eye already open on the table.
This is the ultimate nightmare scenario.
That is the scenario that fails you the exam and, more importantly, harms the patient.
Okay, let's pivot to pre-op, part C. I'm looking at the patient. We mentioned they're usually elderly and diabetic. But there's a specific concept here in the ARC source material called the axial length trap. This sounds like physics again. What is axial length, and why is it trying to kill my patient?
This is one of my favorite exam viva questions because it really separates the technicians from the clinicians. Axial length is simply the distance from the front of the cornea to the back of the retina.
Okay, a front-to-back measurement.
Yes. In a normal, healthy eye, it's about 23 or 24 millimeters.
So 24 millimeters, standard.
But think about why people get retinal detachments. Often it's because they are highly myopic, severely nearsighted.
And I remember from basic optics that nearsighted eyes are longer, right?
They are physically longer. The globe has stretched over their lifetime. A high myope might have an axial length of 26, 28, even 30 millimeters or more.
So the eyeball is just bigger. Why is that a trap for the anesthetist?
Imagine a balloon. If you blow it up to its normal size, the rubber is thick and strong. If you keep blowing, overinflating it, stretching it out, what happens to the rubber?
It gets incredibly thin.
Exactly. In a highly myopic eye, the sclera, the white wall of the eye, stretches and becomes paper thin in some places. This is called a staphyloma.
I see where this is going. The needle.
Yeah, you're right there. If you take a standard 31 millimeter needle for a retrobulbar block, a block which is designed for a 24 millimeter eye, and you stick it into the orbit of a patient with a 28 millimeter eye, that eye is taking up much more space where the needle is supposed to go. And the wall of that eye is paper thin.
You're going to spear the globe.
You will perforate the globe. You will put the needle right through the back or the equator of the eye and inject local anesthetic directly into the vitreous cavity. It destroys the eye. It's an indefensible complication.
Just from doing a routine block.
Just because you didn't check the A scan or the biometry report. So the gold standard exam answer is, as part of my preoperative assessment, I will specifically check the biometry scan for the axial length. If it is long, and the cutoff is generally anything over 26 millimeter, I will strongly avoid any sharp blind needle techniques like a retrobulbar block.
That is a distinct, actionable patient safety point. Check the axial length. So if it's long, what do we do instead? Is that where Sub-Tenons comes in?
Exactly. Sub-Tenons is a blunt technique. We'll get into the details of that in the technique section, but the guiding principle is sharp needles and long, thin eyes do not mix.
Got it. Now, apart from the eye's geometry, let's talk about the patient's meds. Anticoagulants. This is always a fight with the surgeon. They want zero bleeding. The cardiologist wants the patient not to have a stroke. Where do we land for VR surgery?
It depends entirely on your needle. If you are doing a retrobulbar block, you are sticking a sharp needle blindly into the muscle cone right next to the ophthalmic artery and vein. If you nick a vessel there, you get a retrobulbar hemorrhage,
Which pushes on the eye from behind.
It causes an orbital compartment syndrome, the pressure skyrockets, it cuts off the blood supply to the optic nerve, and the patient goes blind. So, for retrobulbar blocks, the consensus is that coagulation must be normal. You stop the warfarin, you stop the clopidogrel.
But we just said retrobulbar is risky anyway in these patients. What if we do that blunt Sub-Tenons block you mentioned?
That's the beauty of Sub-Tenons. Because it's a blunt dissection under direct vision, the risk of causing a serious vision-threatening hemorrhage is tiny. The modern consensus, and this is supported by the Royal College guidelines and the ARC notes, is that you can safely continue aspirin and even warfarin as long as the INR is in the therapeutic range for Sub-Tenons blocks.
So shifting our technique to Sub-Tenons solves both the perforation risk in myopic eyes and the anticoagulant headache.
It solves almost everything, which is why, spoiler alert, it's going to be our technique of choice when we discuss this later on.
Okay, I want to pause in the conversation with the patient. You mentioned earlier that the operating table is a torture device for someone with heart failure. How do you actually assess that pre-op? Do you just ask them, can you lie flat?
Asking is not enough. You have to simulate it. Patients will almost always say yes because they're anxious and they want their surgery. Then, 10 minutes into the case, they are suffocating.
So what do you do?
I literally make them lie flat on the trolley in the holding bay. I put a pillow under their knees because severe back pain is the other big killer of cooperation, and I see if they can last for 5, maybe 10 minutes without coughing, gasping for air, or becoming distressed.
The 5-minute flat test.
Exactly. If they start coughing or their oxygen saturation drops in 5 minutes in the holding bay, they will never, ever survive 90 minutes under the drapes. That patient needs a general anesthetic, not because of their eye, but because of their inability to tolerate the position.
That's a great clinical pearl. Don't take their word for it. Test the position.
And while you're there, check the airway. It's standard Mullen-Potty and neck movement stuff. But remember the population. Elderly patients often have stiff necks from cervical spondylosis. If you need to intubate in an emergency and they have very limited neck extension and you're in a dark room with limited access, you need to know that beforehand.
Okay, that makes perfect sense.
Yeah.
Let's move to Part D, anesthetic techniques.
Yeah.
We've hinted at the GA versus local debate. What is the current trend? Where is the pendulum?
The pendulum is definitely swinging. Historically, VR surgery was almost all general anesthesia because of the prolonged duration and the need for absolute stillness. But now, with better local techniques like Sub-Tenons and better, safer sedation agents like dexmedetomidine, more and more centers are doing these cases under local.
So if I get an exam question asking me to compare them, what are the key columns in my mental table?
Okay, for local anesthesia with sedation, the pros are fantastic hemodynamic stability, less post-op nausea and vomiting, which is a huge deal, and faster recovery and discharge.
And the cons?
The cons are patient anxiety, the risk of sudden movement, and the chance that the block wears off before the very long surgery ends.
Okay. And for general anesthesia?
The pros are guaranteed, perfect akinesia, the eye does not move. The airway is completely secure, the patient is comfortable and unaware. The cons are the significant physiological stress of GA, the risk of coughing and bucking on emergence, which is a disaster for IOP, and the much higher rate of post-op nausea and vomiting.
Let's drill down into the regional technique. We've established that Sub-Tenons is the winner for safety. Talk me through the procedure as if I'm learning it for the first time. It's not just a simple needle poke, is it?
No, it's more of a small surgical dissection, which is why it's so much safer. You can verify this in the long and short cases text. First, you anesthetize the surface of the eye with topical drops. Then you ask the patient to look up and out.
Up and out. Why that specific direction?
It exposes the inferonasal quadrant of the globe, which is the safest and easiest place to access. You take a pair of fine, non-toothed forceps, and you gently lift the conjunctiva and the underlying tenon's capsule. That's the fascial layer around the eye.
So you're tenting it up.
Exactly. You're tenting it up away from the sclera. Then you take small, blunt-tipped Westcott scissors and make a tiny snip to open a hole into the subtenon space.
So you are actually cutting the surface.
A tiny, controlled cut, yes. Then you insert your cannula, usually a Stevens or Greenbaum cannula. The key is that it's curved to match the globe, and it's completely blunt. There's no sharp tip.
Ah, that's the key safety feature.
That's it. You slide this blunt cannula into the hole you made, and you gently push it back, following the curve of the eyeball, until the tip is well behind the equator of the eye.
Because it's blunt, it just follows the path of least resistance between the layers.
Precisely. It slides easily in the subtenon space. It's incredibly difficult to perforate the globe with a blunt metal tube unless you're being extremely rough. Once you're back there, you inject your local anesthetic mixture.
What's a standard cocktail for that?
It's usually a slightly higher volume compared to a retrobulbar block, maybe 3 to 5 milliliters. It's a mix of lidocaine 2% for a fast onset, bupivacaine micro 0.5% for a long duration, and crucially, hyaluronidase.
The spreading agent.
Exactly. Hyaluronidase is an enzyme that temporarily breaks down the connective tissue matrix. It helps that puddle of local anesthetic you've injected to spread all the way around the entire globe, blocking all the motor and sensory nerves. It turns a localized puddle into a global bath.
That's a great description. Okay, now let's say we have to do general anesthesia. Maybe it's a child, a highly anxious adult, or someone who can't lie flat. The outline mentions the LMA versus ETT debate.
Yes, this is always a point of discussion. The laryngeal mask airway, or LMA, is fantastic for a smooth emergence. You can often pull it with the patient quite deep and they barely cough or react. That's wonderful for keeping the intraocular pressure stable.
But there's a but, I'm guessing.
There is, but remember where you are. You are 5 feet away, in the dark, with the airway completely covered by drapes. If that LMA dislodges, or if the patient has laryngospasm, or if they regurgitate, You have an unsecured airway that is physically inaccessible.
That sounds terrifying. So the ETT is the safety belt.
The endotracheal tube is the gold standard for security in this situation. For a trainee in an exam, if the question describes a complex, long VR case, the ETT is always the safer, more defensible answer. You just have to manage the extubation phase with extreme care to avoid the bucking.
Bucking on the tube. That sounds like an IOP nightmare. How do we prevent it?
There are a few strategies. Deep extubation is one option, but it's risky in obese patients or those with reflux. The more common way is to achieve a pharmacological smoothness.
With what drugs?
Intravenous lidocaine, about 1.5 mg/kg, given a few minutes before you plan to extubate, is excellent at blunting airway reflexes. Or a small, carefully titrated dose of a short-acting opioid like remifentanil or alfentanil. The goal is to have them wake up essentially without a cough reflex for those first few critical minutes.
The smooth landing.
Exactly. The whole surgery can be perfect, but you can ruin the entire repair with one big cough at the end. You can't stick the landing if you crash on the runway.
Let's move into Part E, intraoperative management. This is the real physiology engine room. We keep talking about IOP, intraocular pressure. Why are we so obsessed with it?
Because the eye is a closed, pressurized box with a very delicate and high-flow blood supply. Normal IOP is between 10 and 20 millimeters of mercury. If it drops too low hypotony, the eye can collapse and structures can bleed. If it goes too high, from glaucoma or acute spikes, you compress and crush the blood supply to the optic nerve and the retinal artery.
And cause ischemia.
Permanent ischemic blindness, so we need to keep the pressure stable in that sweet spot.
Okay, so what are the enemies of stability? What makes IOP shoot up?
The biggest enemy, by far, is venous congestion. Anything that impedes venous drainage from the head and the eye.
Like coughing.
Coughing, straining, vomiting, any kind of Valsalva maneuver. This causes the choroidal veins inside the eye to engorge dramatically. If the eye is open, it can literally push the contents of the eye, the retina, and iris right out of the wound.
That's a vivid image.
It's called an expulsive hemorrhage. It is the absolute catastrophe of intraocular surgery.
What else affects it?
Head position. If the head is lower than the heart in a Trendelenburg position, IOP goes up. So usually keep a slight head up or reverse Trendelenburg tilt.
What about ventilation and our anesthetic gases?
Carbon dioxide is a potent vasodilator. So hypercarbia, a high CO2 level, causes choroidal vasodilation, which swells the choroid and raises IOP. You want to maintain normocarbia or even slight hypocarbia. Don't let them hypoventilate under the drapes.
Okay. Now, positioning considerations. We talked about the table, but the outline mentions pressure point care and this wrist rest. What is the wrist rest issue?
This is a very practical safety point examiners like. The surgeon uses a sterile, adjustable metal bar that goes over the patient's forehead. They rest their wrists on it to stabilize their hands while they do the microsurgery.
So there's a metal bar right over the patient's face.
Yes. There are two risks. If the patient is not deep enough and moves their head up or bucks, they can smash their forehead or even their eye socket into this metal bar. Or if the surgeon leans too hard on it for 2 hours, they can cause a pressure ulcer on the patient's forehead.
So the head needs to be completely fixed.
Taped down, literally, with strong adhesive tape taped to the headrest on the table, which, again, makes your airway access even harder. In an emergency, you have to find scissors and cut tape just to get to the mouth.
All right, okay, here we go, the big one. Point 11 in the outline. Intraocular gas tamponade. The outline calls this very high yield. This is the physics section. Explain this to me like I'm a first-year resident who just walked in and has no idea what's happening.
Okay, let's use that wallpaper analogy again. The retina has peeled off the wall of the eye. To get it to stick back on, the surgeon needs to press it against the wall while the glue they apply, usually laser burns, takes effect.
Okay, wallpaper needs to be pressed to the wall.
They can't use a physical hand inside the eye, so they use a gas bubble instead. At the end of the surgery, they inject a bubble of a specific inert gas, usually SF6, which is sulfur hexafluoride, or C3F8, which is perfluoropropane, into the vitreous cavity.
And the bubble pushes on the retina.
Because gas is lighter than the fluid in the eye, the bubble floats up. By positioning the patient's head correctly, the surgeon can make that bubble float up and press directly on the retinal tear. It acts as an internal splint or a tamponade.
A pneumatic splint. That's clever.
It is. Now, here is where the anesthetist can single-handedly destroy the eye. We have to talk about nitrous oxide.
The laughing gas.
It is no laughing matter here. This is all about blood gas solubility. Nitrous oxide is extremely soluble in blood. The surgical gases, SF6 and C3F8, are very insoluble. How much more soluble? Well, nitrous oxide is about 117 times more soluble in blood than SF6 is.
117 times. That's a massive difference.
It is a colossal, game-changing difference. So let's set the scene. You, the anesthetist, are running 50% nitrous oxide in your ventilation gas mixture. The patient's blood is saturated with dissolved nitrous. The surgeon finishes the repair and injects a pure bubble of SF6 gas into the eye.
What happens next?
Basic physics. Fick's law of diffusion kicks in. The huge amount of nitrous oxide in the blood sees this gas bubble, which has zero nitrous in it, and it rushes from the blood into the bubble to try and equilibrate the partial pressures. It rushes in incredibly fast because of its high solubility.
And the SF6 in the bubble, does it rush out?
It tries to, but it's a large, heavy molecule with extremely low solubility. It can only diffuse out of the bubble and into the blood very, very slowly. So you have a massive net influx of gas into the bubble.
So the bubble grows.
It doesn't just grow, it explodes in size. Within 15 to 20 minutes, the volume of that bubble can double or even triple. But the eye is a rigid, bony sphere. It can't stretch. So the pressure inside skyrockets. We were talking about IOPs of 50, 60, 80 millimeters of mercury.
Which completely clamps off the central retinal artery.
Instantly. And the patient wakes up permanently blind from an ischemic optic neuropathy caused entirely by the anesthetist's choice of gas.
That is horrifying. So the rule is absolute.
The rule is absolute, non-negotiable, and a major exam failure point. Strictly avoid nitrous oxide in all vitreoretinal surgery. If there is even a remote chance the surgeon might use gas, just don't turn the cylinder on. Use an air and oxygen mixture from the start.
What if, and this is a classic Viva question, what if I used it for induction and then turned it off?
That's the trap. You must allow for a washout period. You need to discontinue the nitrous oxide and run high fresh gas flows for at least 15 to 20 minutes before the surgeon injects the gas. But frankly, in real life, why take the risk? Just avoid it entirely for these cases.
And this isn't just an interop problem, is it? That bubble stays in the eye for a while?
Correct. That's the next critical point. SF6 gas lasts for about 2 weeks. The longer-acting C3F8 can last for up to 8 weeks. While that bubble is in the eye, the patient enters a strict no-fly zone.
Boyle's law, pressure and volume.
Exactly. If they go up in an airplane, the cabin pressure drops. As the external pressure drops, the gas bubble inside their eye expands just like a bag of chips. The IOP goes through the roof and they have an eye rupture or go blind.
So no flying.
No flying, no travel to high-altitude cities, and this is critical for us if they need another surgery, say for a broken leg 2 weeks later.
The next anesthetist cannot use nitrous oxide either.
Exactly. The patient must be given a warning card or a wristband that says, gas and eye, do not use N2O. It's a huge patient safety issue that extends long after they leave our care.
That is a massive safety point. Okay, Part F, complications. We've talked about the gas disaster. Let's talk about the reflex, the oculocardiac reflex, or OCR.
The 5 and dime reflex. This is high-yield physiology. For the exam, you need to be able to state the reflex arc perfectly.
Okay, walk me through the arc.
The stimulus is pressure on the globe, or more commonly, traction on the extraocular muscles, especially the medial rectus. It's the most sensitive.
So the surgeon pulls on a muscle, then what?
That sensory signal travels along the afferent limb, which is the trigeminal nerve, specifically the ophthalmic division, V1. The signal goes to the brainstem, to the sensory nucleus of the trigeminal nerve.
And then?
From there, it connects via interneurons to the vagal nucleus, which is the motor nucleus of the vagus nerve, located in the floor of the fourth ventricle. The efferent signal then goes down the vagus nerve, cranial nerve 10, to the heart.
Trigeminal in, vagus out, cranial nerve 5 in, cranial nerve 10 out.
Correct. And the result of that vagal stimulation is profound bradycardia, sometimes a junctional rhythm or even a few seconds of a systole. The heart just slows right down or stops.
So the monitor starts beeping. The heart rate on the screen is 30. What do you do? Step 1.
Step 1 is not drugs. This is crucial. Step 1 is tell the surgeon to stop. You say clearly and calmly, please stop the stimulus or stop pulling. In 90% of cases, as soon as they release the muscle, the heart rate comes right back up to normal.
That's pretty satisfying, I imagine.
It is. If you rush to give atropine while they are still pulling on the muscle, you are just chasing your tail. The stimulus is overwhelming the drug. Stop the stimulus first.
And if the heart rate doesn't come back up after they stop?
Then you move to step 2. Check your ventilation. Ensure adequate oxygenation and ventilation, because hypoxia and hypercarbia both make the reflex much, much worse. Only after you've done those two things, if the bradycardia is still persisting, do you give an anticholinergic drug like atropine or glycopyrrolate.
Stop, ventilate, medicate. Got it. What about post-op complications? This brings us to part G.
The big ones are nausea and positioning. Pain is usually mild, but severe pain is a red flag. It could mean dangerously high IOP from a hemorrhage or gas expansion and needs immediate review.
But the unique misery of VR surgery is this posturing thing.
Yes, the face-down positioning.
Why do they have to do that?
It's pure physics. If the gas bubble is there to tamponate a tear in the macula, which is at the very back of the eye, the bubble only works if it floats up against that tear. For that to happen, the patient's face must be pointing down towards the floor.
Gravity. The bubble has to rise to the right spot.
They have to spend 50 minutes of every hour for days or even a week in a prone or face-down position, sleeping face down, eating face down. It is grueling.
That sounds absolutely grueling for an 80-year-old with a bad back.
It is. And as anesthetists, our responsibility is to ensure they are physically capable of this before they even have the surgery. We also need to make sure that in the recovery room, the nurse knows not to prop them up on 3 pillows on their back if they lie supine.
The bubble goes to the wrong place,
It moves to the front of the eye and sits right against the posterior surface of the lens.
causing a cataract.
A gas cataract. It can form incredibly quickly. So the positioning instructions are a critical part of our anesthetic handover and discharge planning.
Okay, we are in the home stretch now. Part H, exam integration. We need to synthesize all of this. The outline asks for comparison tables. If I'm asked in a Viva, compare regional versus general anesthesia for VR surgery, summarize the winning points for the examiner.
Let's visualize that table for the exam. For regional anesthesia, your advantages are superior hemodynamic stability, excellent post-op analgesia, significantly less post-op nausea and vomiting, and it facilitates early discharge.
And the disadvantages.
Disadvantages: risk of globe perforation with needle techniques requires patient cooperation, which can be unpredictable, and the risk of retrobulbar hemorrhage.
Okay, now for general anesthesia.
Advantages of GA guaranteed, perfect akinesia, a completely secure airway with an ETT, and it's the only option for children or uncooperative adults.
Disadvantages.
Disadvantages: significant hemodynamic swings on induction and emergence, the high risk of coughing or bucking, which can spike IOP, a much higher incidence of PO and V, and of course the ever-present risk of the nitrous oxide and gas interaction.
That's a very clear breakdown.
Yeah.
And if they ask for a simpler comparison between cataract and VR surgery.
Even easier. Cataract surgery, short duration, usually 15-20 minutes. Topical or simple block anesthesia is often sufficient. Standard supine positioning. Low risk of major systemic physiologic shifts.
In VR,
VR surgery, long duration, often 90 minutes or more. Requires a dense block or general anesthesia. Demands absolute, strict immobility. Carries the unique risk of gas tamponade and the associated nitrous oxide contraindication. And it may require difficult post-operative posturing, like face down.
perfect. Let's hit the Viva traps one last time to really hammer them home. Trap number 1. The surgeon announces they are about to inject SF6 gas. You look at your anesthetic machine and realize you are running 50% nitrous oxide. What do?
Your immediate answer is, I would turn off the nitrous oxide immediately, increase my fresh gas flow to maximum to wash it out, inform the surgeon of the situation, and ask them to please wait 15 to 20 minutes before injecting the gas if surgically possible. The better answer is, in my practice, I would not have been using nitrous oxide for this case at all to avoid this very scenario.
Excellent. Trap number 2. You see in the notes that the patient has an axial length of 28 millimeter. The surgeon asks you to do a retrobulbar block. What do you say?
I would respectfully decline to perform a retrobulbar block due to the high axial length, which significantly increases the risk of globe perforation due to a potential staphyloma. I would offer to perform a much safer Sub-Tenon's block, or, if preferred, we could proceed with general anesthesia.
And let's not forget the diagrams. If I'm in a written exam and have a chance to draw something.
You must draw 2 things. First, draw the OCR reflex arc, a simple box for the brainstem. Show the trigeminal nerve coming in, the vagus nerve going out. Label everything. Second, draw the gas bubble expansion graph. Show time on the x-axis and bubble volume on the y-axis. Draw a flat line for arrow 2 anesthesia and a steep, dramatic upward curve for N2O anesthesia. That graph is worth 5 marks on its own.
Fantastic. Let's wrap this entire deep dive up with a final summary. If I'm walking into the exam hall or, frankly, walking into Theater 4 tomorrow morning for a VR list, what is my final mental checklist?
Here is your summary checklist. 5 key points. 1. Respect the case. It is long, it is complex, and it happens in the dark. Do not underestimate it. 2. Assessment is key. Check the axial length to save the globe, and meticulously assess the comorbidities to save the patient. Test their ability to lie flat.
3.
3. Technique matters. Sub-tenons is your safety net for regional blocks. If you're using GA, your number one priority is a smooth emergence to protect the surgical repair.
4.
4. Intra-op vigilance. Watch for the oculocardiac reflex and remember to stop the stimulus first. And the absolute rule, and no nitrous oxide if there is any chance of intraocular gas. This is non-negotiable.
And the last one, number 5.
5. Post-op care. Use aggressive, multimodal PONV prophylaxis and ensure the patient and nursing staff understand the critical importance of face-down positioning if required.
That's a brilliant summary. And a final closing thought for the listener to take away.
I'll leave you with this thought. In most surgeries, the anesthetist's primary role is to keep the patient alive and comfortable while the surgeon does the work. In vitreoretinal surgery, the anesthetist creates the conditions that make the surgery possible. Without your stillness, your pressure control, and your vigilance in the dark, the surgeon cannot succeed. You are an active partner in saving their sight. Take that responsibility seriously, know your gas laws, and you will ace the exam and, more importantly, be a safe and excellent clinician.
Perfect. That is the anesthetic management of vitreoretinal surgery in a nutshell. Physiology, physics, and pharmacology all wrapped up in a dark room. Good luck with the revision, and we'll see you on the next deep dive.